What's up, everyone? Jeff from Lewis Physical Therapy and Sports Rehab here. I want to talk today about the loading protocol that I use for UCL and flexor tendon injuries. We're going to dive into this pretty in depth here, but a couple things I want to just kind of mention before we get right into it. This is a framework that I've kind of just developed. Now, I have developed this after looking at research from kind of other just kind of tendon leading experts. So if you want to go look on your own, there's going to be Jill Cook, Emily Rios, Keith Barr. So a lot of stuff from those individuals, and then I've kind of just, with the population I've seen specific to baseball players, kind of adapted it a little bit just based on what I've kind of seen in the clinic here more than anything. So again, this is a framework. This can certainly be applied to, if you look at a lot of those individuals I mentioned, the research is Achilles tendinopathy, patellar tendinopathy. This is kind of what I have found specific to the medial elbow in pitchers. Now, when we kind of talk about, the reason I say UCL slash flexor tendon here, I look at these two as one and the same more than anything. And I used to not to until when you look under kind of like diagnostic ultrasound, the flexor tendon and the UCL run, I mean, so close to one another. So it's really hard, in my opinion, to be able to distinguish the two without kind of, without saying that there's not a connection between those two structures, the UCL and the flexor tendon. So with that being said, I do think, this is just kind of my personal thought based on things that I've seen, I think to a degree, a lot of the UCL injuries we are seeing are just essentially chronic, not flexor tendon injuries, but chronic wearing of that flexor tendon that over time that tendon cannot be able to accept and dissipate load from a pitching standpoint. And as a result, it propagates to the UCL, and that's where these UCL injuries happen. So, when we look at tendon, the whole goal of tendons is energy storage and release. The goal of it is, again, to absorb energy and then dissipate it across the appropriate structures. When you don't have that, well, the tissue, the energy and force has to go somewhere. And in my opinion, a lot of times, that is from the UCL. The reason that I believe that is the case is because in a lot of individuals, I will do a lot of very specific isometrics and eccentrics to their medial elbow when they have clear UCL symptoms, and we do a lot of that, and it clears it up. And we know the flexor tendon, the flexor pronator group is a massive dynamic stabilizer for the medial elbow, but I think that just, again, that type of treatment approach, in my opinion, has just proved and shown to me that takes away some of that quote-unquote ligament stress that they are getting. So this is why I look at these as kind of one and the same. Now, obviously, some UCL surgeries, when people have to get them reconstructed, they have a flexor tendon component into it. So I do think there's a difference between the kind of pathological flexor tendon and just the flexor tendon that just gets beaten up over the years, and as a result, the stress goes to UCL. So we're going to kind of jump right into this. One thing I want to mention is that if you look at the top right corner here, these are a lot of the main groups that we are hitting. We're hitting the FDS, FCU, brachialis, and the pronator, and mainly because those have the ability to minimize that valgus stress medial joint gapping during the throwing motion. So early stage here, actually what I should say, this could be either from a conservative, so non-operative, or a surgical standpoint. Obviously in a surgical case, there's going to be certain, it's going to be obviously a lot slower, especially if someone has a flexor tendon repair. We are not going to be doing any flexor specific work for probably about 6 weeks or so, give and take. That depends on the surgeon. So be mindful of that. But this is just a general framework of early, mid to late. And for the purpose of this video, late is essentially preparing them to return to throw. Because once they start throwing, that becomes their main plyo task, and we just kind of find a way to maintain these. So early stage, this is again, either right out of surgery or right after an injury. Pain is at its highest. There's probably some inflammatory component going on here. So really, more than anything, we are doing strictly isometrics for the involved groups. And really what I'm trying to do here is I'm trying to go for isometric stimulus 2 times a day. So we want to have at least 4 to 6 hours in between. I'm not going to get into the kind of whole physiology of that, but in general, we want to have at least, just say morning and night or morning and afternoon, having that good time in between. 4 sets of 30 seconds per muscle group. Generally, I've gone longer, I've gone shorter. It depends on the individual. But these are relatively lower intensity, long duration isometrics. You want to give yourself at least, depending on the individual, a minute, or 30 seconds to a minute of a break in between. And we want to do these in protected ranges. So what I mean by that is we're starting in probably an elbow flex position, and then maybe working to an elbow extended position depending on their just passive and active range of motion that they have within a comfortable range. We are not getting into any valgus positions either up top here, no valgus down at the side here. These are very, again, protected ranges, and we are just trying to accumulate load into this tissue, get the kind of analgesic response, but also, again, just getting some load into that injured part of the tendon and the UCL. And again, I'll probably have another video kind of explaining a little more in depth as to why we kind of go for the long duration versus shorter duration early on. But again, this is the general structure. So we might do this for, 5 to 6 days a week. Saturday, Sunday, I kind of leave as optional to a degree. But this really should not, they should not be getting very sore from this. It should be just continued stimulus more than anything. And what we also want to make sure here, I don't have it written down here, is we want to make sure for those 30 seconds, it is a slow buildup into that 30 seconds. So it's not a 3, 2, 1, go right to your intensity. You are gradually, over the course of 3 to 5 seconds, you are building up to your goal intensity. Let's just say 30 to 40 seconds here in this case, or 30 to 40%, excuse me. And then you're holding that, and then you're slowly ramping down. We are trying to minimize tendon jerk. So tendons, when they're injured, they do not like the kind of higher velocity movements. That's why for individuals with flexor tendon and UCL injuries, they cannot pitch, which is a high velocity movement on that tendon. So that's why these are all very slow based, nothing fast. So going on to the mid stage here, we are going to continue with our longer duration isometrics, but now we are starting to get more into kind of our strength phase of our isometrics. So we are dropping the volume a little bit. We're giving a little bit more sets, like 3 to 5 sets of about 20 seconds here. And if you look at the structure here more than anything, well, before I go to that, I'm going to stay over here. We are now starting to introduce some valgus and up towards some kind of like arm release or release point or arm slot position. So that's going to be more of like, we might start here at the side at a neutral abduction, but adding in some ER here. And again, this is dependent on each individual. A post-op, I'm going to go through more of these stages, more likely. In a non-surgical or a low-grade strain, I'm probably, not that I'm going to skip some steps, but I'm not going to spend maybe as much time in one position. So we'll start down here. We'll move up to a kind of neutral rotation abducted position, get into 90-90, different elbow angles, arm slot release. So just things like that. We're starting to introduce those positions here at a little bit of a higher intensity. We are still having that slow build up in intensity. So we are not going into any kind of fast building up into intensity. It's a slow 3 to 5 second build up. And we are now starting to add in some eccentrics and concentrics. So in this case, this really more than anything is a way that we are going to get some slow move or some slow tension throughout that tissue more than anything. So perfect example is if I'm having someone do with like a cable or anything like that, some FDS specific kind of curls on a cable, it might be a 3 to 5 second eccentric and then a slow 3 second concentric. Again, it's not a slow eccentric and then a fast concentric. We are minimizing that tendon jerk, giving it a chance to adapt. If you look into some of the tendon neuroplastic training from Emily Rios and Jill Cook as well, they do kind of talk about the use of a metronome. I think it's a good way to. I've done that with some people before. If anything, it keeps you honest on your tempo without getting too much into that. But that is an option as well for your patients. So again, these are kind of the general considerations of this stage. So when we look at the weekly structure, we have a day here, still some 2 times a day of some longer duration isometrics. Again, low intensity. This should serve as more of a recovery more than anything to prepare for the upcoming days. And then we go into our next day. This is going to be our warm-up isometrics. So we're not going to do as long duration here. It's still relatively lower intensity, 30 to 50%, but we're dropping down to 10, maybe 15 seconds for only a couple sets, depending on each position. And then we are going to go right into our strength isometrics. So again, that's kind of our 3 to 5 sets for 20 seconds. We're now getting a little bit higher to that like 60, 70, maybe upwards of 80%, depending on where they're at in their continuum. And then again, we're pretty much alternating. A longer, low intensity day, strength. Longer, low intensity day, strength. So you're getting 2, maybe 3 strength days in a week there, depending on the individual and how they're responding overall. So that's that. Moving on to our late stage. Now, what I will say, this is a phase where, and I've been guilty of this too, people tend to get really plyo happy with a lot of things. I have just found that I used to do a ton of plyos with guys, and there's nothing wrong with that, but a lot of athletes, particularly pitchers, are great compensators, meaning their body finds a way to perform that motion. You give them something to throw. They've been throwing for years, probably even a decade at that point. They're not going to necessarily forget how to do that. So I personally have pulled back on the amount of plyos I've done, maybe from a med ball standpoint, and done more like kind of ball drops in different positions. And I've taken more of this time to load them specifically at the medial elbow. Because what I have found is I could do all the plyos with these guys, but if I kind of skip this phase here that we're going to go over, they really still struggle in this phase. So for me, I'm kind of like, well, why are we trying to rush into plyos, but they're not necessarily prepared for it? When throwing is a plyometric activity itself. So for me, if you try to raise both at the same time, this is basic just kind of training organization. You can't peak 2 things at the same time and get the best result. One, something has to give. So if you try to do a ton of plyos and a ton of this late stage strength that we're talking about here, you're going to have some interference of quality. So I personally have pulled back on the plyos. You still do them as a way to just kind of prepare them not only physically but mentally for throwing, but I spend more time in this phase here. So again, this is the late return to throwing part. So we are now progressing their strength. So we're maybe doing 3 to 6 sets of 10 to 15 seconds. And these are a lot higher intense. We are at minimum 80% here. And again, we're still, for this strength side of things, we're still taking a gradual buildup. It's still a 3-second buildup. So today we're going to 80%. It's a 3-second of 20, 40, 80. And then we're holding for that time. And we're just really trying to get higher intensity here for a lot of these muscle groups. And we are in these cases, really maximum valgus, arm slot, release. We're continuing to push the intensity of these eccentrics and concentrics. We're going to be upping the weight, but keeping that tempo the same. So we're just pushing the intensity of these things we're doing here into more stressful positions from a throwing standpoint and into our strength isometrics more than anything. So when we go kind of in this phase here, so again, we still have a recovery day here. Okay, so we have kind of at least one. If they need a second, they can. But I would say actually this second one is probably going to be optional more than anything. So you have that long duration day here. Iso warm up, like we talked about before. We're now going into our strength isometrics here. And this third day is going to be much more of our kind of plyo rate of force development. So plyo is going to be more of our ball drops. And then our rate of force development. So with the rate of force development, the difference here is, we've up to this point done slowly building up to that kind of higher intensity. Now we are trying to say, hey, it is 3, 2, 1. Go immediately right to that high intensity, 80, 90, 100%. Hold it for 3, max 5 seconds, and relax. So we are really trying to prepare that tendon for that very fast kind of energy storage and then dissipation of energy, which is essentially throwing more than anything. So that is why we kind of have this on our own separate day. Now, what I will say is, there have been times I've had this be done on the same day as strength. It is very dependent on the individual. If they get really cooked from their strength work the day after, you might have to move this day here and kind of have it all on one day and just have more recovery days during the week. That is fine, but just as a way to kind of stretch, stress out these stimulus, that's what we're looking for here. So again, that's how we position this kind of RFD work and the strength work in this phase. We are still doing eccentrics. We are still doing all that stuff. But again, for me, I have personally, as I've kind of gone through my career, have put more stock into the higher intensity loading and higher intensity RFD, only because I have seen guys be able to do a lot of plyo stuff, but then you put them into this and they really struggle with it, which for me, I would rather take more time maxing them out here from a very local stability standpoint, because to a degree, these UCL and flexor tendon injuries, in my opinion, are a failure of the local stabilizers. So we really hit that for a certain period of time, and then throwing is going to be their main plyometric more than anything. So again, if you look at the week here, you're potentially getting 2 strength days, 2 plyo and RFD days. If you need to, based on your athlete, you compact these into one day, so you potentially get 2, maybe 3 days of that, but you do get more time from a long duration kind of isometric recovery standpoint in there. And again, this is specific to the forearm. We are still doing a ton of shoulder work. We are still doing a ton of scap work. We are lifting the entire body, lower body core, the injured arm as well. But again, once we kind of look at it from this framework, in my opinion, we are better preparing that UCL, flexor tendon, really just the medial elbow stabilizers for a return to throwing. And once we do return to throwing, that might be a video for another point, but we are still trying to maintain some of these qualities. So you have a recovery day. You have more of a strength day, like eccentrics. You have more of a strength isometric day. Your RFD stuff is maybe in your warm-up to a degree. So there's a lot of ways to go about that. Again, this is a framework. I don't want you to think you have to do exactly this. This is just what I've kind of developed based on some of the research and listen to other experts and listen to some experts in the field more than anything. So take it, look at it, see how it can apply to, if you're seeing baseball players, how it applies to them, or to just other tendinopathies you're dealing with. So if you have questions on this, drop it below in the comments section, or go ahead and subscribe to our channel for more content like this.